Hello, it's roughly 12 o'clock, so let me move this back a little bit or something like that. And hi, I'm Elliot Fishman, and welcome to Facebook Live. Today is February 4th. It's 2 days after Groundhog's Day. It's many months since I last got a haircut. Look at that. I'm telling you, I need, got a ponytail. Should get a haircut soon. 2 vaccines down, so I guess it's safe to get a haircut. I'd like to welcome everybody. Today is Worldwide Cancer Day, and so we'll talk about that in a moment. Just a few other comments. One is a week from Saturday, we will be having our first virtual meeting. So anyway, hopefully it should be great. We have 10 lectures. We'll do some Q&A. I think it will be very, I think it'll be a lot of fun. So, and hopefully, again, so there's no confusion, if you want CME credits, so that means you're typically US techs or docs, you need credits. It's 8 CME credits for docs or for techs. If you want credit, then you're going to have to register. It costs $100 for a doc, $50 for tech, so it's really cheap. If you just want to attend the course, so a lot of our friends from around the world, CME credits really don't help any, particularly USA CME credits. So then you just need to show up at the lecture, and we expect a few thousand people, so it should be a lot of fun. We have terrific speakers, myself, Linda Chu, Stefan Zimmerman, Tony Lin, Atif Sahir. All of us recorded. Well, the way it's going to work, I mean, being practical with Zoom these days, all of us are recording lectures. The reason you see all this stuff in the background, I'm in my dining room, which we never use anyway, except I record things in my dining room. So for when I do lectures, because it's a really easy, very quiet room. And so I recorded 3 lectures for CTisus this morning. Then I recorded one of my 3 lectures for that Saturday meeting already. Then I have 2 more that I need to record, which I'll do sometime today, and that will be sent in tomorrow. And then what we'll have is that we'll be able to do Q&A. The Q&A will be live. My introduction will be live. So there'll be, otherwise everything will be, recorded. You really can't tell the difference because, you just can't tell the difference whether we're doing it live or not. But that'll be fine. And it begins at 8 o'clock next Saturday, February 13th. We'll end on or about 4:30. So it should be great. So for National Cancer Day, just a couple things. When you think about CT in general, the biggest application we have in CT, I mean, we do trauma, we do high-res lung, we do all sorts of things. But at the end of the day, we do lots of cancer, whether it's patient with symptoms of weight loss, abdominal pain, GI bleeding, whether it's a patient with a cough. So we scan patients because they have symptoms and we're worried about cancer. We have patients who have biopsy-proven cancer or known cancer. We stage them with CT. We follow up patients once they get chemotherapy or radiation therapy or when they get surgery. We prepare patients and define what the management of the patient should be. Pancreatic cancer, that's Tuesday, today's Thursday. Tuesday we have pancreas at Hopkins. At that meeting we looked at 12 patients, determining whether or not patients are surgical candidates. If they're surgical candidates, do they need chemotherapy or radiation therapy first? We determine what patients aren't surgical candidates and what needs to be done. Okay? And so we do all of that, and imaging, and CT in particular, is what really defines it. And CT really has changed everything. In fact, I'm writing an article, co-writing an article, that'll be out this year because this is the 50th anniversary of CT. CT came out in 1971. And so this is 50 years. So what are the main impacts? And one of the biggest impacts is going to be oncology. I'm looking at my, so people can make comments. So just looking at comments, one of the things, I know Lily put it up, though her name is not there, is about our CME meeting. So it's there. You can follow the link. You can see it there. And then we'll say hey to Meg Fines. Hey, Meg, who's in New Jersey. And then Jose Ruiz and Slavik Tyruk. I don't know where they are, but they sound somewhere exotic. In terms of CT, I think a lot of the work that's being done now with CT continues to be on protocols, technique, but I think a lot of the stuff you are seeing and particularly when you talk about oncology, and this is National Cancer Day, is screening. So we are using screening CT. Screening in general, you read a lot, has kind of taken a little back step because of COVID, where people were afraid to go. And so whether it's mammography, with volumes dropped 90% in the beginning, or it's virtual colonoscopy, or it's lung cancer screening, screening in general has taken a slight beating. CT's good if you think about the screening. Colon's been proven to be good, virtual colonoscopy. Screening patients who've been smokers, so for lung cancer, that's worked out very well, saves a lot of lives. Whole body screening was something we did in the past. Because of radiation dose and other issues, mainly false positive, that tends not to be done much anymore. Though when we did a work with Geisinger Health System, Bert Vogelstein and Ken Kinsler and all the people from Thrive, looking at the blood tests, we figured that the best way, once the blood test is positive twice, then you need to find a tumor. Where's the tumor? And I decided to do PET CT, and that worked very nicely. I would say most of the lesions we saw on the CT, then you may have seen them also on the PET. Typically saw them on both. And a couple I saw only on the PET, and retrospectively I saw on the CT. So, and people in Japan have used PET CT for screening. So when you look at the things we do with CT, it's not just CT as a unit modality, but also when you combine it with PET, obviously tremendous value in the oncology patient. I think when you look forward in terms of oncology, I think the biggest changes are going to be related to artificial intelligence. I think that's going to be really big. It's becoming big. As you know, we're doing pancreatic cancer, looking at early detection of pancreatic cancer, or earlier detection of pancreatic cancer with CT scanning. CT scanning is reproducible. You can control some of the parameters, and so it works very nicely when you look at AI. And remember, AI to work needs to work across all scanners and modalities. Needs to be not very specific protocols to really make it a value. So I think you are going to see a lot of cancer is in AI. And when I talk about AI in cancer, it's not only in helping you read the scans. That will be a big part, but it's only going to be a big part and a small part at the same time. One of the things that's challenging to us is same patient, same stage of disease, and different outcomes. What is going on? We're doing so much more with genetic markers, so we're learning why people respond to chemotherapy, why some people do well with tumors and why some people don't do well with tumors, why someone with an unresectable tumor with positive margins is around for a 10-year follow-up, and why somebody with negative margins, no spread, is not around for a 1-year follow-up. We know so much more about cancer than we ever have known, but I think the one thing I know is kind of to quote Don Henley, the more I know, the less I understand. All the things we thought were obvious are not so obvious again. I screwed up the last line, by the way, in the song, but if Henley was rewriting it, that's how he would have written it. But I think it's very important to realize with AI, we want to look at pancreatic cancer, colon cancer, you pick the cancer, breast cancer, and look if you can predict from the imaging as well as lab values as well as history how patients' outcomes are going to be. Can you predict that? They're showing AI can be used in sepsis patients to figure out who's going to do well and who's going to do poorly. In COVID, how should you manage the patients depending on their x-rays, or CTs rather? How should you manage them? How aggressively? Can you predict who will do well, who will not do as well? Prediction. People talk about customized medicine, or many of the different words, personalized medicine. To me, that's what you want to do. You want to get the best treatment for that individual patient, but it's really understanding not just the person, but understanding the entire consortium of people that are involved, trying to figure out what is it that we can learn from the people who don't respond as well as from the people who do respond. Why some people who shouldn't make it do, and why those who should make it do not. We need to really learn a lot. I don't think we know enough. And I think when you have AI is going to be able to analyze the data and look at parameters and do all sorts of calculations, figuring out what is this parameter set? Why does this work? Why did this person do well? And why did this patient do poorly? And I think AI is going to be a great driver in cancer. Often you have a few different drug treatments. AI will help you predict what patient should get what treatment, what the length of the treatment is, who will benefit from radiation, who will not benefit from radiation, what chemotherapy works, and what chemotherapy doesn't work. That becomes very, very important to us. It's not going to be just the oncologist, the radiologist, whoever combined coming up with decisions in multidisciplinary conference. You're going to have to look at what the data shows based on larger pools of information. That is something that we are seeing. I think COVID hopefully has pushed that along. Remember that if people wouldn't share data, if people worried about proprietary nature of things, we would still be in the worst of shape with COVID. It's not great shape yet, but in less than a year, we've not only found the virus, figured out what it does, how to treat it better, developed drugs for that, and now we have vaccines which hopefully will eliminate or make it less of a problem. So, but it was a sharing of data. The first people made the genetic code of the vaccine, of the virus, and its spikes and everything else. And they didn't say, okay, it's our information, good luck to the rest of you. It was immediately shared. And I think in the human endeavor, when you look at science and medicine, you really need to have people be able to share things. If people don't share information, you're going to be twiddling around for a long time. Now, with COVID, it was a worldwide emergency. People knew they needed to share, that business as usual was not going to be good enough. And I think maybe that's what needs to be done in cancer. I'm not saying, and this is a little bit too quaint because people always say it, you need a Manhattan Project where, we rushed, put all the bright minds together to develop a nuclear bomb. Maybe it's somewhat like that, but I think you need to be able to share information, share knowledge, learn best of practice. Why should I do something that doesn't work when someone else could have told me, Elliot, don't do that. I tried it already. 3 other people tried it. It doesn't work. But people don't publish typically what doesn't work. They only publish what does work. So you don't even know that somebody had done it before, and you don't know that it didn't work. So I think the way we do things really has to change, and people have spoken about that. Medicine should not be political, so we want to make certain that things are not political. We don't want you to be wearing a mask because you're a Democrat and now wearing a mask because you're a Republican or you believe in one candidate or the other. You want to get back to the point where science is science and therapy is based on what's best for the patient, not what somebody wants to say because it seems to be better for their point of view. I mean, we need to be separate. And oncology is the best example. Oncology is driven by results, by measured outcome. There's lots of drugs available, but having a drug available is not the same thing as a drug working. And some drugs work for some people and don't work for other people. And so much now is being into looking at genetic profiles on patients routinely to help predict what does work and what doesn't. To say someone has pancreatic adenocarcinoma, there's so much more information that you can get now that really digs deeper into that patient's genome. And that's the information we need if we think that we can make massive progress. Otherwise, we're going to be going through that same thing again where it's kind of, well, we treat the patient, hope for the best. We always hope for the best, but you need to be thinking about how you can really do better in predicting. Predictive analytics becomes very, very critical. Can we predict how you're going to do, and is there a logic rather than saying, well, you'll probably do it right. That's just not going to work. So I think it's a good time if people are running out of time, people want to ask questions, they can ask questions and I'll be happy to answer them. I think when you look at things like National Cancer Day, I think we have to be grateful for all of these steps forward. I think things like liquid biopsy, the stuff that Thrive did with Bert Vogelstein and Ken Kinsler, and now that's owned by Exact Sciences, who did Cologuard, very strong company out of Washington. And hopefully they're going to be pushing where you'll be able to get a blood test, and 5 years before your tumor shows up, you'll know that you have a propensity for tumor of a certain type, and then you'll be able to treat it earlier, or you'll be able to do some genetic modification that will prevent the disease from developing any further, and then you'll be able to regress the disease and prevent the cancer from starting or happening in the first place. So I think that becomes a very, very critical thing. I think with cancer, on a cancer day, you got to be thinking that we need to have big time innovations, simply small changes. This drug is this is 82% accurate, and this other is 81, or now it's 83, so we're up a point. We need like home runs. We need like the equivalent of the vaccine for hepatitis B, where you get it and you no longer have hepatitis V. We need that cancer vaccine. People have been working on vaccines at Hopkins and elsewhere. It's never quite gone as well as you see from vaccines. We are learning a lot now. Hopefully, I think one of the things like Moderna, Pfizer are going to learn from doing this whole COVID thing is some of the things they learned about how to test, how to produce things in a more rapid fashion, and really how to target things with mRNA. So I think that part's very exciting. So I think there's a lot of good things coming along. Other than that, I hope everyone's doing okay. We're still, as everyone, hopefully a lot of you who are listening to me have gotten your 2 shots already, or at least 1 shot, based on the data, particularly from Israel. That protects us a lot. It doesn't mean you can't get COVID, so you still need to behave. You cannot be going around without a mask or anything else. So I think it makes you feel better. I don't know if you ask me when meetings are going to start again. The first thing to me is you're not going to have meetings for the most part till people are willing to walk around without a mask. When are you not going to be wearing a mask? I have no idea. No one even bothers predicting that because it's such a difficult prediction. Nobody wants to be wrong. Are we going to be wearing masks for the next 3 years? I mean, that may not be really pretty. But we're going to have to do what we need to do. And maybe if it's masks, we'll have to wear them. But it's hard to predict what's going to happen. So with that, happy National Cancer Day. Hope everybody is doing well. And if you have any questions, come to CTisus. We'll be happy to answer them. We're putting up a lot of new content from new lectures and cases. We've upgraded almost all the apps on the Apple Store. There's a lot of really new, super cool stuff. There's more super cool, unbelievable stuff coming along over the next few months. And with that, I'll just say have a great day.